ठीक आहे. पार्टिसिपंट मीच एकटा.
किती वेळ लागेल सुरू व्हायला?
वेळ आहे जाणार.
Good evening, everybody. Who is answering today? Hello? Who is answering today?
Sir, Aditya and Anand. Dr. Aditya and Dr. Anand.
Okay, so I'll unmute them. So Anand Bhuktar and Aditya.
Yes, sir. Good evening, sir.
Yes,
Yeah.
sir. Good evening.
Okay. So Anand Bhuktar and Aditya Goel. Two of you are answering, correct?
Yes,
sir.
Yeah. So just go, means when we show you all the three different cases, judge them on their merit. Don't keep one diagnosis in your mind. Okay.
Okay.
All are very interesting cases. So another 1 minute and we are starting. Good evening, Ganesh and Mahendra and Hiren.
Good evening, sir.
Good evening, sir.
So Rahul is also answering today. Rahul, you are answering, correct?
Yes, sir.
Good.
Good
So
evening,
Rahul,
sir.
Anand and Aditya. Mahendra, can we start now?
Yes, sir. We can start.
Okay. Brijesh? Okay. So Rahul,
Yes, sir.
Anand and Aditya. Okay. So
Yes, sir.
step by step, means in the history, we will go little fast. So we will ask one name and then you can answer accordingly. Fine.
Yes, sir.
Okay. So Rahul, this is a history.
Yes.
How will you go ahead?
60-year-old. Yes.
Sir, 60-year-old male presented with a mild pain over the left flank pain since 1 month history of hematuria. Sir, I would like to elaborate the onset, duration, and progression of the left flank pain, as well as I would like to elaborate the hematuria also, sir. Sir, in the flank pain, I would like to see the flank pain is dull aching or colicky, mild, moderate severity, number of episode of the pain, then whether pain is associated with fever, chills, whether it is associated with nausea, vomiting, whether it is associated with any aggravating and relieving factor, and sir, pain if it is relieved by taking any medications. Sir, about the pain, I would like to ask all these things. And in view of hematuria, sir, I would like to know about the hematuria is painless or painful hematuria, whether it is visible or gross hematuria or microscopic hematuria. Then a number of hematuria episodes, whether it is associated with the clots, whether it is associated with the lower urinary tract symptoms, any tissue bits passing through the urine, whether this hematuria is associated with any previous history of endoscopic procedure, whether patient is on any antiplatelet. Sir, all these factors I would like to ask in this patient.
Okay, so Aditya, you want to add anything?
Then,
Sir, apart from this, I would like
Only
to know whether
extra
there was
thing.
any,
Anything else you want to add?
sir, any history of
Yes, sir.
dysuria is there or not? Any patient is a known case of stone disease in the past or not, sir? For hematuria, whether it was terminal or total hematuria, and if present clots are present, then the shape of the clots is present.
Yeah. Anand, you want to add anything?
Yes, sir. Yes, sir. And also the non-urological causes of the left back pain, like colonic and splenic is associated with non-urology.
Okay, fine. Okay, Brijesh, just show them the full history.
So he was asymptomatic before 1 month and started complaining of very mild pain in left flank region. Pain was dull, aching, non-colic, inside is gradually progressing and not associated nausea, vomiting, or fever. Was relieved on taking analgesics. Patient also noticed passage of blood in the urine in 10 days. It was sudden in onset, painful, non-progress, self-limiting. Hematuria was complete as a few amorphous clots, and symptoms were insidious and gradually progressive with no specific error relief.
Go ahead.
There was no history of any dysuria, leukorrhea, or no instrumentation, no vomiting, no any bleeding disorders, no anticoagulant therapy, or no any radiotherapy, no trauma.
then, sir, I would like to know about the personal history of the patient, family history, and past history of the patient.
Okay. Before that, Mahendra, you want to advise them anything in the history or something?
I think trauma was missed in the history of flank pain and the hematuria. I think rest everything is covered, but with the hematuria and flank pain. Why family history is important?
Yeah,
So family
Anand.
history is important.
Some of the diseases are familial, like VHL, running the family, some von Hippel syndrome, BRCA mutations, genetic association. They run in the
Yeah,
family.
so you can say any autosomal dominant kidney diseases which can create a flank pain, because they all can create hematuria. Okay, that is
Yes.
that you can say in the exam. Good. Yeah.
Brijesh, go ahead.
He was non-diabetic. He was a known case of hypertension. He was taking telmisartan 40 milligram for 7 years. Family history was no contributory, and he was non-alcoholic, non-smoker, and he didn't have any any addictions.
Okay, Anand, so now next what you want to do? So looking at the history, what are the probable diagnoses that comes in your mind? Anand,
Sir,
first you answer, then Aditya, and then Nayak. Three of you answer one after another.
So looking at the history, sir, so stone disease was first diagnosis, followed by renal cell means upper tract malignancy, then mm, stone disease, upper tract malignancy, then GUTB also in the lab, liver downstream, then
See,
Apart from
you
this,
are not
renal
answering in theory paper, okay? So whatever you're routinely seeing in your clinic and you are operating them, please tell us. So Aditya,
apart
what are the different diagnoses that comes to your mind?
So most commonly would be a stone disease, sir. Then any upper tract malignancy, it can be either RCC or UTUC, sir. Then it can also be a bladder malignancy, sir. Any renal cystic disease could also be one of the possibilities, sir.
Mm-hmm. Anand, your voice is not very clear. Can you come little nearer to the
okay,
mic, and talk little
yes,
louder? Okay.
okay, sir. Yes.
Okay, Swapnil. So what is your probable diagnosis, and then we go ahead.
Sir, I would like to keep differential diagnosis in the order of first is stone disease, after that renal cystic disease, after that ureteric junction obstruction, and after that I would like to keep as a renal malignancies along with the upper tract urothelial carcinoma.
Okay, what is the triad and
Sir,
what is the significance?
Sir,
Good
flank,
correction.
flank pain, hematuria, and flank fullness, palpable mass.
Mass.
Yes.
So the significance is that it is present only in 15% of the cases, sir. And usually it is a marker of late presentation, sir.
Right.
So the classical triad would not be present in majority of the cases of, for renal cell carcinoma, early renal cell.
So what are the causes of pain
Sir,
in cases of malignancy?
Sir, pain is due to the
Stretching of the renal capsule, sir. Necrosis, hemorrhage.
Involvement of the surrounding organs, involvement of the nervous system also leads to the pain in this case.
Which nervous system? Be specific.
Sir, perirenal nerves are involved in the local spread.
No, you can just say you just mentioned about the surrounding structures. That means the muscles are involved. The nerve roots are being compressed by the mass. Okay.
Yes.
So what do you mean by perirenal nerves? You are again getting something that you cannot answer. Now the question will go from the nerve supply of the renal capsule and perirenal fat. Then you do not know. Enough?
Yes.
So be specific. What in large any mass, any flank pain? What are the causes give you the flank pain?
The stretch of the renal capsule. Then, sir, in the mass, in the large mass, there is a.
Why are you saying mass? Why are you saying mass and mass again and again? That means you know this is a renal mass case. Stretching of the capsule, intrarenal hemorrhage,
necrosis. Sir, necrosis of the tissue.
Necrosis will not give pain. You are doing which is radiological finding. Inflammation of the kidney. Lying only one stone in the kidney will not cause pain until it moves into the ureter.
So,
Okay.
Swapnil, I ask you about the late triad, and then the question came. But Dr. Mahendra Pal is asking you, what are the causes of pain in case of any renal presentation? So, in that, you have to answer all these things, that the stretching of the capsule,
Yes,
or it
yes.
can be because of over distension of the, dilatation of the pelvic alyceal system, right?
Yes,
Then, as you are saying that, yeah, it's a clot colic, or it can be because of the extravasation of urine, irritation of the nerve, root nerves, or infiltration of that, dragging pain, and infiltration of the muscles.
yes,
Okay, fine.
yes.
So I think
Okay.
if everybody makes a note of all these causes, so maybe it will be, instead of learning at the online class, and don't make the notes. It is useless thing. You should make notes after the class.
Yeah.
Okay, sir.
So every question you ask, you write down the answer. If examiner asks you why you asked this question and what is the purpose or what is the answer to this, then you should be able to answer. Okay?
Yes.
Brijesh, go ahead.
In general examination, everything was normal. Pulse, blood pressure, respiratory rate, and oxygen saturation normal. Abdominal examination inspections were normal. No any renal angle fullness. Palpation, there was no any palpable lump or mass. Rectal examination, prostate was grade 1, form inconsistency, and normal rectal mucosa.
He has no tenderness in the flank. He was having pain
No, sir, at the
on
time of examination, he was not having any tenderness.
during palpation.
Yes.
Okay.
So Aditya, so why Mahendra Bhai has asked this question? What is the meaning of that? He had a pain, but
Yes, sir.
on examination, on palpation, there was no tenderness. What is an inference?
Sir, stone disease is one thing that we may rule out by this, sir, because a patient who presents to us with pain in a stone disease should usually has a flank tenderness or a renal tenderness is there, sir. Once the patient on palpation is not having any tenderness significance, sir, that could be one of the possibilities.
So in this case, probably because he was passing clots, he had pain, correct?
Yes.
And now
Yes, sir.
the clot has passed away. There is no other major illness in the kidney, like there is no big mass, or there is no pyonephrosis, or there is no, tense hydronephrosis or extravasation, perinephric spread, right? So
Yes,
all these
yes,
things, probably it is not there. And that is why he is not getting any tenderness.
right.
Right. Okay. Brijesh. Okay. So now what you want to do?
So to reach to a diagnosis, we would like to get a few blood investigations, sir, like a complete blood count, serum creatinine, a urine routine microscopy examination is also required, sir. And along with that, an ultrasonography of the abdomen and pelvis is needed.
Okay. What is the age of this patient?
60-year-old.
So now the question is, I will also like Dr. Mahendra to answer that. Whether we should ask for a PSA in this patient?
Sir,
Okay,
a
Aditya
PR
Anand,
finding,
but
if PR
Mahendra,
finding
let
is
them
normal.
answer first. Aditya
Yeah,
Anand,
okay.
Aditya, you tell us first. Whether you ask for a PSA or you will not ask for PSA.
Since the patient does not have any significant elutase symptoms, sir, prior to this, sir. So we can discuss with the patient about the PSA, but as the patient is not asymptomatic, we should not. For
So
a
you will
routine
not ask
evaluation,
for
we can.
PSA.
Yes, sir.
Sir, according to the US Task Force recommendation of prostate cancer surveillance, age group between 55 to 70, we can ask for serum PSA as a routine investigation.
So you will ask for a PSA, correct?
Yes, sir. I would like to know the serum
Okay. And
PSA
what about the
level.
Anand?
Yes, sir. I would like to ask PSA.
Okay, fine. Mahendra bhai, what
First
will
of
be?
all, yeah.
Yeah.
So, sir, first of all, they have to correct themselves with that US task force and everything is the screening PSA that is in asymptomatic patients. So, in a symptomatic patient having hematuria, anything, so this is not a screening one. So that is not applicable over here. Yeah, or in hematuria and in abnormal DRE finding, PSA is mandatory, but in a normal PR finding, not so large, PSA is plus can be omitted, can not be done until it is indicated clinically like that. Because in hematuria, without any clinical finding, PSA is not a recommended test.
Sir, as per definition of lower urinary tract symptoms, it is divided into voiding symptoms and storage symptoms. But hematuria is not a part of any lower urinary tract symptom. So, as such, this patient is asymptomatic and 60-year-old. So, he can fit into the US task force definition.
But he is having hematuria.
But sir,
So again,
hematuria is not a symptom of lower urinary tract symptom, as well as it is not any symptom for prostatomegaly.
are you sure? Prostatomegaly cannot give hematuria?
Sir, it can give rise to hematuria, but on the only 10% of the patient can give rise to the hematuria in prostatomegaly.
So, okay, but according me, maybe Dr. Bakshi sir can, if he's here. Sir, are you there? Bakshi sir? Okay, but anyway, I don't think so. With hematuria, I should advise a serum PSA.
Yes.
Yeah, as an indication of US task force, that
Yes.
recommendation is not applicable over here.
Yes.
Yeah. And I think this patient was not having LUTS, if I'm not wrong.
Yes, sir. He's asymptomatic.
Yeah. So LUTS with hematuria, with some doubt in DRE, you can do serum PSA. Patient having LUTS, hematuria, maybe to rule out infection, then you can do serum PSA.
Yes.
Yeah. Okay.
These are the investigations.
Pankaj bhai, you want to say anything about PSA? Whether he should ask for PSA or not in this patient?
So I would want to say that, sir, this cannot be called as screening. Though patient doesn't have LUTS, it is still not screening. The task force recommendation are for general screening, a patient coming just for a regular health checkup, that type of screening, or you go to community to do the screening. This is now a patient who has come to you with urological symptoms, and I would definitely get a PSA done in this patient.
I think this is a right answer.
Last class also, sir, it was discussed. I think Ganesh had also said that many of the times the students are confusing between screening and when to ask PSA. So some of those recommendations are for screening, and I think in this case, even I agree with what Pankaj sir and Mahendra are saying.
You see,
Yeah.
at best you can call it as opportunistic screening, but this will still not fit into a regular screening. So regular screening will be, say, we go to community and do a PSA of all men more than 60 years of say some club. That is a screening. But a patient who walks into your consulting with lower urinary tract symptoms, this is a part for completion of evaluation of that patient.
Fine. So please remember, whenever patient comes with lower urinary tract symptoms or something like this, urological problem, and he is falling in that age group, we will advise PSA. Fine. Okay. Bridges, go ahead.
This was the urine routine microscopy.
Okay, can you say that pus cells are there, but there are no RBC? Anand, can you just tell us, patient is giving history of gross hematuria, and now there is no RBC. Aditya, can you just tell us why it is like this?
So maybe the patient at that, when he noticed hematuria, at that time there was some clot which passed, and now there is no etiology specifically for to have an RBC.
So that is one thing, and second thing is there are more chances that it is coming from the upper tract rather than something is, because otherwise there will be at least some microscopic hematuria if it is only from the bladder, right? So these are the two things which we have to keep it in mind. Okay, Bridges, go ahead.
And sensitivity was also normal. There was no growth.
Go ahead.
Sonography was done. Sonography suggested left kidney.
One more thing I want to add. Patient having hematuria, one thing living is a cytology. That is a part of investigation in hematuria. Urine cytology.
So, how will you collect urine for cytology? What are the instructions you will give to the patient while collecting urine for cytology?
Swapnil, you answer.
So, second sample usually, sir, not the first one early morning. Second sample in 3 successive days you will collect it. And
can you explain why second sample and why 3 successive days?
Post-ambulatory. That was the first word you should have said.
What is the problem in collecting the early morning first sample? Am I audible?
yes, sir.
नहीं, जितना पिन ड्रॉप साइलेंस है मुझे लगा मेरी आवाज नहीं जा रही है.
Aditya, you answer.
Yes. So basically, we want the first sample would not be a representative sample of the system. So we want to discard the first sample, and we take 3 samples to increase the sensitivity of the cytology report. So if a single sample is also adequate.
What happens if you take the first sample?
Yeah.
Why it will not be representative? Rather, it's a sample which has got collected over 8 hours, so probably more representative.
Nice. Hemolyzed.
Hemolyzed is not the right answer. We are not looking for blood cells here. We are looking for malignant cells. So what happens to malignant cells if it remains in urine overnight?
They get denatured, so we'll not be able to identify the malignant cells if they stay in urine for a long time.
Yes.
The
So you will not be able to pick up malignant cells if the urine is an overnight collected urine sample. It should be a freshly voided, not the morning sample. And like in culture, we ask for a midstream sample. Here you would ask for a complete urine sample, which should be minimum 25 ml and more. And 3 samples, as you rightly said, is more to increase the catch or sensitivity. So it could be anywhere from 3 to 5 samples. As we have seen in one of the samples, you did not find RBCs, but in the culture sample, they wrote innumerable RBCs. So it is not necessary that you will see the abnormal cells or blood cells in every sample. So you take it over multiple days.
Okay. So now, Aditya, now what you want to do? This is the ultrasonography report.
So the sonography report suggests of a left side needle mass. So to know the if available, I would like to see the films of the sonography, or else then would like to confirm the characteristic of the mass by getting a triple phase contrast CT scan of the abdomen and pelvis.
Films were not available. That's why report was directly kept. CT
I
report.
think at this stage, go step by step. Don't directly jump to CT scan. First, see the USG report until it is asked what next test you want to do. Then you answer CT scan.
Okay.
The art of giving a viva is if you give extra answer, then examiner will lead you. If you give answer only what is asked, then you can lead the exam.
Right.
Pankaj sir, if I am not wrong.
Absolutely correct.
Yeah.
Fine. So this is an ultrasonography report. It is saying that there is a left renal mass. So now, Aditya, what you want to do? You are saying that you want to do what investigation?
Since the creatinine of the patient is normal, sir, a triple phase contrast and CT scan of the abdomen.
Okay. And why you want to do it? Triple phase?
I want to see the characteristic of the mass, sir, and in the delayed phase, I would like to delete the pelvic calyceal system, sir, and to see
But before that, I would like to ask you what are the characteristic features of renal malignancy on the sonography?
So it is usually a heterogeneous mass, sir. Would be irregular heterogeneous mass with mixed density as well. Along with we maybe see some calcifications also on sonography, sir, that can be appreciated with the central necrosis.
Okay. What else?
Vascularity.
Yeah, internal vascularity.
Internal vascularity. Doppler.
Yes, on the Doppler, and it is always not ill-defined. NSS where you will see small masses are always well defined. Okay.
Yes.
Yes. Okay.
Bridges, go ahead. Show them all the films. So Anand, can you describe it?
So it is a contrast CT scan of the abdominal pelvis, sir. On the left kidney, it shows a heterogenic mass and some calcification within. On the lower pole, involved in the pelvic calyceal system, sir. In the nephromatous score, sir, around 4.
So which are the different ways? You are calculating by which method?
Renal nephromatous. Renal.
So what is renal?
R is for radius. It is less than 4 is 1.4 to 7 is 2.9, more than 7 is 3 point. E is exophytic, endophytic means 1 point is for more than 50% exophytic component. Less than 50% is 2 and completely endophytic is 3, and is nearness to TCS, sir. It is if it is more than 7 mm is 1, 4 to it if it is 4 to 7 mm 2, and less than 4 mm is 3. A is anterior and posterior, sir, and L is relation to the polar lines. If it is one for more than 50% away from the polar line, uh, 2 is for less than 50%, and 3 is near inside the polar lines.
Aditya?
So in relation to polar lines, sir, the score is 1, 2, 3. 1 would be the masses completely outside the polar lines. 2 would be that the masses are touching the polar lines, but not more than 50%. And 3, there would be either the masses more than 50% inside the polar line, or the masses completely between the two polar lines, or it is touching the central line, sir, the line between the two polar lines.
Fine. So,
So what
can
is
you tell us?
what is H and X? What is H and X? Anyone?
Not sure, sir.
H means hilar, and X means cannot be defined by the anterior, posterior, or hilar. Okay.
Okay.
Yeah.
Thank you, Mahendra.
Yeah.
Okay, so what is the renal score? Aditya, you can tell us?
Roughly would be, sir, around about 7, sir.
7 to
8.
8.
What is the size?
The size would be somewhere between 4 to 7, sir. Roughly.
2, sir.
So a
So
score
2.
of 2, sir.
Then
it is partially exophytic, sir. So again, a score of 2, sir.
2.
Then nearness to
Involving
hilum
PCS.
seems to be near the hilum, so 3, sir.
3, 7.
And
Crossing the polar lines at 50%.
polar lines maybe 1 or 2, sir.
9, sir. I was saying 9.
8 or 9. Yes.
so it is 9. Fine.
Yes.
Just see.
Yes.
Okay. So it
Yes.
is, they are saying 9A because it is anterior.
Right.
So which are the other methods?
So Padua score, centrality index, DAP
Can you
score,
tell us Padua score step by step? Tell us about Padua score.
centrality. Sir, depending on Padua score, sir, location of the tumor, sir. Then exophytic, endophytic component, as is involvement of renal sinus, and then involvement.
Swapnil? You know Padua score? Aditya, you tell us.
Not sure about the so it involves the nearness to the hilum, the size, sir. Then the involvement of renal sinus, the renal fat,
PCS.
and involvement of the PCS.
So just for a student to learning purpose, it is all renal nephrometry score plus involvement of renal sinus and renal fat.
Okay, sir.
Because you have to just add these two parameters, and then Padua score is done.
Other one is the centrality index.
What is that?
Okay.
That is, sir, it's a ratio of distance between the center of the kidney to the center of the tumor divided by radius of the tumor. The more the centrality index, less complex will be the tumor.
So
It
now
is
you
slightly-
calculate in this. Can you just calculate? Explain us. Anand, don't worry. If you are wrong, no, don't worry. Just tell us. How will you calculate
Actually,
in this?
Gaurang sir, this C index need measurement of the length with the axis of the mass in the kidney.
Kidney, sir.
So yeah, it needs multiple images to describe that. So Can you go back? Yeah. So in this case, the axis of the kidney is in the in the white line, and we see the which axis the tumor is lying over the kidney. This axis. It is little bit complicated. Even we do not do routinely. We actually don't use it. Yeah. But you theory purpose, you should know how to measure it.
Fine. So now, Aditya, these are the cases. And which other will you like to do any other investigation?
Sir, apart from this, a CT chest is something that I would like to get done, sir.
Okay.
Before going to the report, can you please tell us in case of a USG, this thing, renal mass or something in CT scan, what are the things you would like to see? What
Sir,
7-8 things you would like to see?
Sir, I would like to see exact anatomical details of the mass, size of the mass, vascularity of the mass, any accessory vessel supplying to the mass. I would like to see. I would like to see the perirenal area, fat standing of the fat standing. I would like to see. Then, sir. And sir, enhancement of the mass, how much it is enhancing in the arterial phase, sir. And then I would like to see, sir, all these things in the renal mass in the CT scan.
Okay. Anyone can who wants to try to define it or describe it?
And sir, one more thing, any lymphadenopathy is present or not?
Okay. So I would like to just try to make it easy for you. When any malignancy in USG or chest X-ray, you find something malignancy is there, so your focus should be find out the TNM staging. Okay, you have to find out TNM staging and see how we are going to find these things in the CT scan if we focus on particular things to find the TNM stage. So T comes first. Okay. So T comes means size and site of the tumor. It's related to the correspondence organ. Okay. It is single or multiple tumor, unilateral or bilateral tumor. So this comes in T stage. Okay. Again, to see the again T stage in renal cancer, there is a tumor thrombus is there. So whether tumor thrombus in the renal vein going to the IVC or not, like that. Vascularity, artery, vein vascularity, the should of that. This T is over. Now comes N staging. N is very simple, means regional lymph nodes are there or not. M staging means distant metastasis, but in renal cancer, the adrenal status of adrenal gland is very important. If it is the upper pole mass, adrenal is involved, it becomes T4. But if it's a lower pole mass, adrenal is enlarged, it becomes M1. Right? So these only 5-6 things you have to see, and you can describe. You can see CT scan in 2 minutes only. Right. If you go into the tumor is heterogeneous, necrosis hai ki nahi hai, calcification hai ki nahi hai, all things you have to see, but is a part of TNM staging. Because necrosis and calcification will guide you about the tumor aggressiveness. That means you can anticipate that its grade may be 3 or 4, not the urban grade 1 or 2. Right. Okay. Yeah.
Okay.
Okay.
So you ask for HRCT. But just show them.
HRCT was normal.
So now next, what you want to do? Anand, I will ask you, just tell me what you want to do.
So it is a localized disease, sir. So I will discuss this issue with the patients and yes, I will give the option of means
Patient had hematuria. You would not like to evaluate the other sites of bleeding in urine?
yes, sir.
So, see, what Dr. Mahendra is asking is very simple. Do you think that it is infiltrating into the pelvic acid system?
So there may be chances of seedling sir into the bladder. So I would like to do cystoscopy also.
So, Aditya, what you want to do?
So on the CT scan, if you're not able to see any bladder lesion, sir, that you're seeing, then or any PCS lesion as well, sir, then we can move ahead with
All in the PCS.
So, what do you want to do? Aditya, tell us.
Yes. Yes, I would like to explain the patient and the relatives about the nature of the illness, the options available, sir, and I would like to proceed with the consent of the patient. I would like to proceed with the open left partial nephrectomy.
Okay. And Swapnil, what you want to do?
Sir, I would like to counsel my patient regarding the disease, and I also like to go for open left partial nephrectomy.
Why everybody wants to do open surgery?
I am more confident
in doing open surgery.
Okay. No, that is okay. Fine. Good answer. You can always say that I like to do this. If patient insists that he wants to go for a minimal access surgery, then I will refer the patient to the particular center.
Yes.
You are right. Whatever you are doing in your center, you can tell. Barabar na, Mahendra?
Yes, sir.
In the exam, I think you should say options of treatment. I will
Yeah.
discuss with the patient. And then you can say, I do this, and maybe if I want to do robotic, I will take a help from my senior. That is fine. But options of treatment should always be discussed.
So, Hiren bhai, it can be both way. That what will you do? So they can ask. They can say, I can.
Correct,
I will perform open nephrectomy. Then they will say what other way you can perform that. Then they can say laparoscopic, robotics, like that. Or other way, they can also say ki it can be performed in the lap, open or robotic way. Then they ask what you will prefer. Then I will prefer open surgery because I know it, because in my center I have been watching this surgery going on in my center.
Sometimes the examiner may say that you will do open, but patient doesn't want open. So you should always say that options of treatment can be discussed, and then you can say, okay, sir, I would like to do this because I'm confident. Whatever.
Okay, so two questions from my side. Before going ahead with the partial nephrectomy and surgery, any role of doing a biopsy in this end, because and how many percentage of renal mass, small renal mass are benign? So role of biopsy and a role of a DTPA scan to find out the functional evolution of the kidney.
Biopsy for renal masses are indicated only if you are planning any active surveillance or any focal therapy, or if it is a metastatic lesion where we need to confirm the diagnosis before starting a systemic therapy. Only in those cases we advise biopsy, or there is a dilemma of diagnosis like lymphoma or say abscess.
Lymphoma, abscess.
And
for a localized renal mass, biopsy will not be recommended.
Patient also has hematuria, where the diagnosis dilemma about the TCC or the RCC.
RCC, yes.
But sir, looking at the CT images, sir, RCC is usually arises in the cortical area. It will not. It will disturb the pelvic acid system. In this, it is abutting the pelvic acid system, and it enhances on the CT.
CT.
So now
And
you
in,
know
sir,
you know
urothelial
Brijesh,
cancer.
Brijesh, now what my next question will be, because now you give me the chance to, I will deviate from you from the RCC and I will go into the TCC. Now second question will be, Dr. Brijesh, in radiologically, can you differentiate between the TCC and the RCC?
Swapnil, he is asking you.
Sir, on CT scan, sir, on the location, sir, upper tract urothelial cancer only confined to the pelvic LICL system, and it represent as a filling defect, as well as sir, it will not go into the cortex. And other around, sir, RCC present mainly in the cortical region, and it abet or disturb the pelvic LICL system. So we can differentiate on the imaging
100%?
basis, sir.
100%?
Sir, no, sir, 100% not, but 100% histopathological confirmation we can say if we need 100% confirmation.
So in TCC, which is locally advanced means which is involving the renal parenchyma, okay, and the RCC that is involving the PCS system. How to differentiate those two tumors by CT scan? The answer is, generally RCC doesn't distorted the renal shape and renal capsule. It maintains the shape of the kidney. But in TCC, it can invade, it can distort the kidney, and it is highly irregular compared to the RCC. TCC again doesn't have this thing calcification usually, but RCC may have calcification. Necrosis, both can have necrosis.
See, both simple and logically, RCC is capsulated, right? Whatever pseudo capsule, whatever it is there. But TCC has no capsule. So it is not going to be very regular tumor, as Dr. Mahendra is saying.
Yes.
Fine. Second question he had asked you.
One more thing, Swapnil, I'm not saying you are wrong. Definitely for the stage 1 TCC, stage 1 RCC, your points are right. But what about T3 disease? T3 disease, then it is diagnosed dilemma. In those cases,
yes,
you can do biopsy. Okay?
Yes, sir.
Okay,
Fine.
next part, the role of DTPA scan.
You will like to do DTPA or you don't want to do? Aditya, will you like to do DTPA scan or not?
For this patient, there is no need of a DTPS. We could see that the contralateral kidney looked normal in size and shape. Sir. It had the normal enhancement on the contrast as well, sir. So for this patient, it is not mandatory to get a DTPA scan. If it's a bilateral disease or if there is any pathology in the contralateral kidney, then I would like to get a DTPA.
So what are the indications of doing a DTPA scan?
So absolute indication are the solitary functioning kidney and bilateral disease. And relative indication is the patient is having some comorbidity like diabetes or hypertension. We presume that later on the patient is land up in renal failure.
Yes. So relative indication you can just understand by this way. Relative.
So relative indication after partial nephrectomy, the remnant of the parenchyma, if it is less than 30 to 25%, then we can go for the DTPA scan.
So how can you predict preoperatively? This 30% will remain, 30% will remain, and how can you see the other kidney function preoperatively? So Absolute
Sir, for
indications are
absolute-
as told, they were absolutely correct. Two indications, bilateral kidney or single kidney tumor. Relative means any situation, any condition, maybe in the past or maybe in the present, that may affect the renal function in future. That like diabetes, hypertension, CRF, previous renal surgery, pyelorthotomy, other things. Then in those cases, you should go ahead with the DTPA scan. Is it clear?
Yes.
Yes, sir.
Yes.
Yeah. Okay. So in this case, you did plan for the open partial nephrectomy. Okay. In which cases or what are the criteria in CT scan where you will not attempt the partial nephrectomy?
Sir, if tumor location is in the hilum or in the
Hilum.
pelvic LSL system, then sir, I would not
No.
go for
I
the
don't
partial.
agree. At present, you can see many videos in the YouTube. People are doing hilar tumor NSS.
Sir, gross
Sir,
involvement of
gross
pelvic system,
system
completely endophytic tumor, and
involving the sir vessels.
in the
So a
So I
patient where
think
after
if Pankaj sir is agree and Gite sir will agree with me, nowadays we are also doing bench surgery NSS for single kidney bilateral tumors. So I think nowadays the main contraindication is that where the remnant kidney will be less than 20-30% and maybe not survive because of vascular compromise state before post surgery. I think only two things where nowadays cannot be done. Otherwise, can be done in every each and every condition. Pankaj sir, what do you say?
Sorry, I missed that part. I was not in the room. I
No,
missed
sir.
the discussion.
I was just saying ki theoretically, definitely any renal mass having a score more than 10 or 11, which has a more complication rate post-operative. But nowadays we have a robot, we have a many technologies. So even bench surgery we can do also. So I think nowadays if only conditions where the remnant kidney remains very less, maybe less than 30%, 40%, and the main vasculature is compromised with the by tumor removal. Only these conditions we cannot perform NSS. I think we have extended the indication of NSS nowadays. What is in the books?
Absolutely true. Means if the remaining residual renal mass is something substantial, then we must attempt for partial nephrectomy.
Yeah. Okay. So, role of FDG PET scan in this case?
for renal masses, FDG PET is not very sensitive.
not related.
Because the kidneys themselves have physiological uptake is there.
Okay. So it is not a primary investigation for staging the disease.
Yes.
Okay.
Fine. Okay. So now, Swapnil, you want to do open partial nephrectomy. Before that, would you like to do anything or directly you give anesthesia and which anesthesia and you will give position and you will go ahead?
Sir,
As
before
the
that,
tumor is involving the PCS, sir, I would like to do DJ stenting first.
You would like to do DJ stenting or you like to put a ureteric catheter?
DJ stenting, sir. Now it's doing DJ stent.
Aditya, what you like to do? Whether you want to put ureteric catheter or not, or whether you want to put DJ stent or nothing?
So on the CT
Sir,
scan, just
DJ
look to abut the PC system, sir. So putting a ureteric is not mandatory, sir, in this case.
Sir,
We
I am
additionally don't.
Partial
same.
nephrectomy.
So only if you have any doubt of say involvement of the PC system, sir, post surgery, it will help us to identify any areas which we have not closed in the renal office. So we can use
Aditya, why there is a hematuria?
That means that as the hematuria, then
Sir,
that suggests that the tumor is involving the PCS.
So, but Aditya is saying it is not involving, na? So he doesn't want to put ureteric catheter. Swapnil, what is the cause of hematuria?
sir, hematuria may be due to the bleeding into the tumor, and that can be drained through the pelvic LIC system that lead to the hematuria, sir.
So there is a connection or no connection?
Sir, maybe
Yes, sir.
there is connection. That's why hematuria is there, sir.
So you want to put ureteric catheter
Yes,
or
sir.
you don't?
Yes, sir. I want to put ureteric catheter.
So Anand, my question is, when you go inside, you will go with an idea to cut the pelvic LSL, mean the calais, or you will like to separate it out?
Separate it up.
Sir.
Deliberately.
So you will not be interested in opening and taking it with tumor.
Sir,
Yes,
for margin,
if
we
it is
should look
involving
for.
the PCS, then I
If
will
involving,
remove it.
sir, we should go and take it with the tumor.
No, logically, what do you
Okay.
think when there is hematuria?
Sir, we should go.
So logically, it is involved as per me,
Involving
like I
and
say, it is involving
taking
the
it out.
PCS. I will
In
remove
such
it.
a case, when there is a doubt that there is hematuria, some history of hematuria, but CT is showing no involvement of PCS, but tumor is very close to the pelvic LHL system, can you do something else just before you start the partial?
We can do an
Can you-
RGP, sir.
Okay, that is one. Can we not just put a flexible scope inside and have a look at the system?
Yes, sir. Yes, yes,
Yes, sir. Yes, sir.
yes.
Yes.
So, Pankaj bhai,
Haji.
what is your say on this? And then we'll ask
So
Mahendra
my
also, because he's
thinking is
regularly
that
doing it.
My thinking is that, sir, hematuria is not an absolute indication of PCS involvement. There are other reasons for hematuria. And in this patient, particularly, if I remember the CT images, there was no distortion of the calacial system, and I did not think that the calacial system was invaded. Rather, a good margin is available. Say the tumor looks to have a good pseudocapsule, and it should be possible to do a partial nephrectomy without opening the PCS. I would put a ureteric catheter so that I can put methylene blue through the catheter to identify
Yes.
if the PCS has opened up. But other than that, I am not convinced, sir, that the PCS is involved. What do you think, Mahendra?
Yeah, sir, I agree, sir. Hematuria can occur when a tubule of nephron is involved by the tumor. Bleeding from that part also can cause hematuria. And obviously, the involvement of PCS system also can lead to hematuria. And for the ureteric catheter insertion, so we used to do this methylene blue things maybe 10 years back. And what we observe, after closing the renal pelvis, whenever we inject methylene blue, there is always some type of leak from our suture line, and we try to suture more, and that sometimes they may lead to more parenchymal injury. And what we found later on, if we identify the PCS opening intraoperatively without putting a ureteric catheter, and we do it in a single layer and double layer, we never find urine leak after that. So for
I agree with you.
last 10 year, we are not using ureteric catheter either in robotic or in the open surgery. But we are very careful identifying the pelvis opening during the surgery.
No, so what I meant was that if you want to put a ureteric catheter, that is probably the only reason why I would put a ureteric catheter.
Yeah,
In our center, we don't
just to
routinely put a
identify.
ureteric catheter. But otherwise, in this patient, I would not insist on a ureteric catheter.
No. Even I am not.
Fine.
So, sir, it is also, sir, just like we used to do it 10 years back, then we change our practice. It's all the institution policy and our threshold.
Most of us are
putting in a
doing
knot.
that. Gaurang
It's
Shah sir was also
individual.
saying That most of us
Yeah.
are doing that only. That if we see the PCS is open, then we just suture it, and that's it. I think the
Yeah.
leak stops nicely. Proximally,
Only
if
thing
distally there is
what
no obstruction, proximal always heals.
so what we do, especially in such cases, we don't close the PCS system en masse. We close the PCS separately. If there's a vessel around it, we suture like we underrun separately that, because what we saw, if we do it mass and somehow there is some AV malformation is there, there's a gross hematuria on
Fine.
Hmm.
So always the suturing is done separately. En
that time
masse
with the clot.
is,
So we
yeah.
are
So en masse
suturing
will,
PCS system separately.
yeah, fine. So nowadays, Dr. Gite also agreed the same thing, that there is no need
Yeah.
of putting a ureteric catheter or anything. If you want, you can put DJ later on in case if you find that there is a leak or it is not resolving. So in this case also, just show the specimen. So a partial was done and this is a specimen. And it is appearing that it is quite encapsulated. Margins are clear, probably clear. We have no histopath report. We will see it. Brijesh, just show them.
So Aditya, how much margin are you expecting or aiming to have in a partial nephrectomy?
Sir, 1 millimeter.
1 mm.
We'll say even a single nephron margin is enough to say it as a good specimen.
Single
So-
cell margin.
Single cell.
How will you decide this tumor needs 5 mm margin, this tumor needs single cell margin? How to decide that?
Sir, we should do the frozen section. After the frozen
That you
section,
have
we
removed
can.
No. Listen, what is my question? My question, how will you decide that how much margin you should take? 5 mm, 1 mm, or single cell, maybe the like enucleation. How do you decide that? Because you have removed the tumor, sent for the frozen, they say margin is 5 mm, yeah, 1 mm. You want to revise the mass, or you want to ask them to, no, I want enucleation, send me back, I will remove the rest of the tissue, whatever I have removed, and I want to give you enucleated specimen. So how will you decide that this particular tumor needs this margin and this tumor can be enucleated?
Depending on the aggressiveness of the tumor.
Pardon?
Without removing, how will you know the aggressiveness?
So see, indirectly, what sir asked, I want to know that thing only. Can you predict pre-operatively the tumor aggressiveness?
No.
No. Okay.
Based
Go.
on the imaging features of the
What else you have? Tell me. Other than imaging features, what else you have to see the aggressive of the tumor pre-operatively?
No.
Now, the next question will be, what are the features or the renal mass features which can indicate towards the tumor aggressiveness?
Size.
This is very, very well removed specimen, sir, with good margin and beautiful.
size would be one of the criteria,
Sir,
which
Sir,
you suggest,
depending upon the clinical criteria, then sir, depending upon what is the age of the patient, whether it is familial or hereditary type, we are suspecting, then we can go for aggressive management in this case.
But you did not give answer of my question. I ask something A, and you are giving me Kaka Gaga answer. So please answer in the ABCD. I want to
Since there are
know the
no
CT scan finding which can tell you if this tumor is aggressive. You need to have a good margin, remove good margin with this tumor.
And he said,
Already
significant
many things are going on in the
calcification
group. Yeah.
calcification or necrosis of the
What is the most important?
Size.
Irregular tumor, which
irregular
is
mass.
not a well-defined capsule. The first one. Second, necrosis, calcification, intrahemorrhage, intratumoral hemorrhage, or presence of lymph nodes, regional lymph nodes. They all are feature of the high this one aggressive tumors, or definitely the larger the tumor. Okay. So, can you tell the steps of partial nephrectomy, open partial nephrectomy?
The patient is given right lateral or left lateral depending on the tumor, and we will give 11th rib cutting incision, sir. Then we will go into the
Anyone?
plane of. Hello.
Yeah, go ahead.
Yes, sir. 11th rib cutting incision, sir. Then we will go to the plane between the
which rib you will decide, and what criteria will decide the rib selection that this rib should be removed, or universal 11th rib. In your whole life, you will do by 11th rib, or there is some rule of selecting the ribs: 10th rib, 11th rib, 9th rib, thoracic abdomen, something like that, or no rib cutting.
Sir, if tumor is large size
large
and involving upper pole, then we can go 11th and 10th rib. And if it is involving the lower pole, we can go for 12th rib.
Okay, so the rule is first of all, your main aim in nephrectomy is to reach the hilum first.
Hilum, yes.
So select that rib in the CT scan where you can easily assess the renal hilum. Okay, and the second rule is that where you can approach the upper 1/3 and lower 2/3 of the tumor. Okay.
Yes.
Yeah. Okay. So you are in rib cutting incision. You have removed the rib.
Then after cutting the muscles, colon is mobilized medially.
So in this stage, you should also know which muscles you are cutting in the incision. Okay.
Yes.
Yes.
Medially,
Yeah.
external oblique, internal oblique and transverse.
No, I'm not asking. You should know that what muscles you are cutting.
Then after cutting the muscles, sir, we will reach the plane between the gerotas.
So other than these three muscles, there are posterior serratus anterior, this is dorsal. These two muscles you cut them. Yeah. Okay, come on, quick, जल्दी बताओ मेरे को steps, फटाफट खत्म करो 2 मिनट में steps. Yeah.
We will enter a space between gerotas fascia and soft fascia, sir, the avascular plane, and we lift up the kidney and reach the hilum posteriorly, and we will dissect the ureter. And if we are able to find difficulty in finding the hilum, we will cut the ureter and lift up the kidney so that it will tend the renal artery. And
you want to cut the ureter in NSS?
So.
You are doing not doing radical. You are doing partial. See in exam, if you do this blunder, Gite sir, आप क्या करोगे?
Gite sir is traveling.
ऐसे मत करो भैया. चलो. Yeah. So what I will do, I will mobilize the kidney from surroundings. Okay. अगर lower pole mass है, so I will just if it is a warm ischemia, depending on the situation. But in this case, I would like to mobilize the kidney from above, from anteriorly, posteriorly, from the duodenum, from the IVC, from the left side, from the colon and the aorta, everything. I want to isolate the vessels because I think this tumor has a multiple arterial supply, 2 or 3 maybe.
Yes.
Yeah, so I have to need to have a proper vascular control if you want to do in cold ischemia or warm ischemia. If it's a no ischemia, then we have to select the tumor properly, like that. Okay, you have mobilized the kidney and you isolate the vessels. What next?
Yes, so we will apply the clamp on the renal artery, keeping the renal vein intact.
No, this is not the step. After that, you have to mobilize the kidney from the gerota from the kidney. You have to expose the mass, keeping gerota over the mass, and mobilize the kidney as much as possible, where you can achieve a tumor removal with the adequate margin, and where also you can apply the sutures. After this, you have to decide whether you want to do a cold ischemia or warm ischemia. Okay? Yeah. Now tell me about the ischemia.
So warm ischemia, cold ischemia, and no ischemia. Warm ischemia is without applying the ice slush, sir. Cold ischemia is with ice slush. And in no ischemia,
so when you describe these things, immediately also describe the accepted time durations of warm ischemia, cold ischemia, and no ischemia.
Warm ischemia would be less than 30 minutes.
Is around less than 35 minutes. And for cold ischemia, less than 45 minutes.
Okay. So it is around 30 to 40 minutes. Is the no defined distinct timeline. Up to warm ischemia can depending on the normal kidney, not the only disease kidney. Normal kidney up to 60 minutes cold ischemia, and warm ischemia up to 30 to 40 minutes. Okay.
Yes.
Okay. What are the various ways of doing cold ischemia? Various ways, techniques.
Applying ice slush, sir, around the tumor or kidney.
That is called surface cooling. Okay. Yeah.
And perfusion, sir.
So what is the main idea of surface cooling?
It will decrease the temperature and energy requirements. It will decrease the metabolic rate of
metabolic activity of the normal parenchyma. So
yeah. So what happened? What is your aim? What is your aim?
To prevent the generation of oxygen species, the active oxygen
species.
species.
To prevent the reperfusion index.
Reperfusion is to achieve a temperature of 17 to 20 degrees over the surface of cortical area. Okay. Yeah. And what are the other way?
The perfusion through renal arteries.
Cold saline. Renal artery. The only drawback is hypothermia and renal artery thrombosis. Okay. And the third one? Which you were trying to do preoperatively, ureteric stenting and catheter and infusion of cold saline rapidly. That is not done nowadays. So only surface cooling is most commonly done. Okay.
Yes.
Okay. Okay. So by this thing, we already discussed about the removal and the closure, everything, how to close. So what complications you can expect in this case? 9A. Score is 9A.
Urine leak.
Sir, intraoperative bleeding, postoperative bleeding, sir, infection that can lead to the urine leak, and a urine leak, if then it is infected, then it lead to the abscess formation.
Okay. Asha, during for the closing of the PCS system and achieving hemostasis, which suture you prefer?
Sir, for pelvic LSL systems,
white rail or
white rail, Vehicle,
Any observable
we
suture
should
would,
use observable suture we can
Any
use, sir.
absorbable suture,
Absorbable.
preferably monofilament.
monofilament.
Monofilament,
Monofilament.
PDS.
Okay, okay, ठीक है. So you name few complications. So how will you diagnose those complications and how will you manage?
So,
So intraoperative bleeding is there. So for managing it, we'll try to underrun the individual vessels which is bleeding, sir, rather than taking in en masse.
local hemostatic agents we can use.
So like surgery
Gel, Surgicel, gel foams we can use to control the bleeding.
It is intraoperatively. I am asking about the postoperatively.
Post-operatively,
Sir,
if you're suspecting urine
post-operatively,
leak, so
Urine
Complications
leak is most common.
complications always occur postoperatively, not intraoperatively.
so if you're suspecting urine leaks, then we would like to
Good
place a
drainage, sir.
digestant and a Foley's
Digestant
catheter for the
and
patient, sir.
catheter Foley's catheter.
But how to diagnose it? Urine
USG,
leak.
sir, bedside
So
USG
if the
we can,
persistent drainage more than 200 ml for more than 7 days, and the drain rate is more than 10 or 10 times the serum creatinine.
Okay. Suppose that serum creatinine is 0.8 and drain fluid is 1.9.
Then
It
it
is
is
not leak.
mixed,
Unlikely.
mixed urine.
Okay. Come on. You will stress and drain fluid creatinine. How will you manage it?
Sir, I would like to put a digestant and keep Foley's catheter for around 2 to 3 weeks.
Mm-hmm. Okay.
And confirm there is no distal obstruction as well, sir.
Okay. And the last option, you can do a also PCL, also divert the urine if there is a
Yes,
small
yes.
leak or maybe big leak or stenting. Okay, fine. What about the last option is again re-explore and suture the leak if it doesn't subside a couple of weeks, maybe 3 to 4 weeks.
Conservatively, yes.
Okay. And what about the hematuria? What are the
Initially,
cause
we'll
of
ask the
hematuria?
patient to, we restrict the mobilization of the patient, sir. Initially, assess how much is the hematuria, how much is the hemoglobin drop. If the patient is requiring significant transfusion, then we can go for selective artery angioembolization, sir.
So
And
what is the cause?
lastly, sir,
What is the cause of
So AV marks the
this hematuria?
patient.
And
Causes.
what are the a typical day you can suspect they arise generally in what postoperative day?
sir, between 7 to 14 days.
No, it is within 7 days. Generally, it can arise, but within 7 days they arise. Okay, it happens. Okay, fine. And anything else, Gaurang Shah, sir? I think covered anything. Gite sir, Pankaj sir.
I think you covered quite a lot of things, almost everything. And we can, later on, so there will be one more class. So now we have got 2 short cases. They are totally different. And your views and Dr. Pankaj Maheshwari's view will be of the great help to decide even for the patient. So Brijesh, can you go ahead with the second case?
So this was a 35-year-old female present with a complaint of pain over right flank region for 4 days. She didn't have any comorbidities, no any fever, chills, tigers, normal clinical abdominal exam, no any past history, no any addiction history, no any familial history. So we did ultrasonography. Ultrasonography suggested of a large homogeneously hyperechoic lesion of 5 cross 4.5 cross 3.1 centimeter. And it was suggestive of faticogenicity, probably angiomyolipoma. There was another angiomyolipoma over right kidney.
Okay. Can we go one slide back, please? Previous slide. 35-year-old. Okay.
So Aditya,
Fine.
now what you want to do?
So we would like to, after a few blood-driven investigations, we'd like to confirm the angiomyolipoma by doing an imaging, sir, and see whether there is any active bleeding in this angiomyolipoma or not, sir, since the patient has come with pain, sir.
Okay. So Anand, what you want to do?
So I would like to do the CT scan, sir.
What type of CT scan?
Triple phase CT, sir, especially HU, sir.
What
Okay.
shout?
Contrast and also.
Yeah. Read. Unfortunately, we don't have all the fields. So
Yeah, patient lost to the follow-up. So right kidney was measuring about 9 by 4.8 centimeters, a large, poorly defined arterial phase hyper-enhancing mass seen involving the interpolar region of the right kidney. In the posterior portal, we associate exophatic components extending into the posterior perineal section, abetting the right psoas muscle. With subtle areas of loss of heart and right psoas muscle. Mass was approximately 3.9 by 3.9 by 4 centimeters and the progressive washout of mass on venous and delayed phases. This is involvement of renal sinuses and there is minimal extension into the upper polar region. Few fat density foci is also seen on the plane scan. No evidence of calcification. There is mass effect on the upper pole calyx with calcite axis. So renal nephrometry score was also given.
fine.
This is the impression.
Just read it.
Yes, large heterogeneous densities, arterial phase hyperenhancing mass seen involving posterior cortex, interpolar and upper pole of the right kidney, exophatic posterior component abetting the right psoas muscle. There is significant washout of the delayed phase and few foci of macroscopic fat seen within the lesion. These findings are in favor of atypical renal, possibly differential of renal malignancy being likely. However, due to its fat component and absence of calcification, less likely differential of atypical angiomyolipoma needs to be considered. The mass reveals nephrometry score of 10, suggestive of lesion of high complexity.
And there is another tiny lesion with mixed density lesion with foci of fat density is seen.
Involving the posterior of the right upper pole and measuring around 9 cross 10 mm. And no evidence of calcific density and reason is too small.
Fine. Okay, Swapnil. So now what is your probable diagnosis? What you want to do?
सर इसकी इमेजिंग है क्या? Do we have?
इसका imaging नहीं है, but if you want, I will tell you. We have done this thing, MRI also, and they had got it done PET scan also. So I can show you those images.
Fine. So okay, fine. So what are the characteristic of angiomyolipoma on the imaging?
The HG of the lesion is less than 15, sir.
Less than 15, sir. Hyper-enhancing. And characteristic absence of calcification, sir. Which will differentiate it from RCC.
It should be like a fat density only if it is a typical AML on the CT scan. And it is less than 20, I guess, not 15.
Minus
with
50,
the minus
20.
and compared to the non-contrast enhanced, not the contrast one. Okay. And what syndrome is with
Wunderlich
tuberous
syndrome.
sclerosis.
Wunderlich syndrome.
Wunderlich syndrome.
Wunderlich syndrome
Sir,
is
no, sir.
something
Is
else.
due to the hemorrhage in the retroperitoneum.
It is associated with tuberous sclerosis.
Tuberous sclerosis syndrome, sir. As
Okay, so you should.
age of the female, age of the patient is 35. As she is a female, I would like to know about her any history of seizures associated with any skin lesion present on the face or
Shaggy
elsewhere
patch.
in the body. No, sir.
Mhm.
That is adenoma sebaceum. I would like to
Yes, ma'am.
look for, and
Okay.
any history of
Yeah.
seizures, any history of
Mhm.
mental retardation. I would like to
Mhm.
know, and similar history in the sir family. I would like to know about.
So there was no any
Okay.
seizures or no any asleep macules or adenoma sebaceous. Patient was completely and clinically fit and fine. No any abdominal lump
Okay.
or
Maybe
Okay.
not
So
associated with
if we go retrospectively and you already know about the Tourette syndrome, so what additional thing you would like to ask in the history, though it's just 35 year of age, female?
Pregnancy.
Pregnancy, sir. Whether the patient is pending
Yes.
any pregnancy or not,
Pregnancy
sir.
pregnancy.
aspect.
Why it
The
is
chances
important?
of the
Incidence of
spontaneous
pregnancy
rupture or
Yes.
syndrome
bleeding
is
is
higher in
maximum
pregnant
in
women.
pregnant ladies.
Okay, so now the next question comes like that. What are the features which may cause lead to increased chances of hemorrhage in the angiomyolipoma?
So size more than 4
4
centimeter,
centimeter.
multiple
Mul-
lesions, uh,
Lipid rich.
best complete.
Abhi, we were discussing about the risk factor, pregnancy,
Yes, the pregnancy.
Hyperdynamic circulation.
pregnancy, and compliance of the patient. Because sometimes these patient doesn't reach to the hospital because of acute bleeding, that is known as spontaneous bleeding, known as Wunderlich syndrome.
Wonderlich.
Okay.
Okay,
Yes.
and about the most of the cases are amenable for nephron sparing surgery, because if they are generally surface tumor and just sweeping away the mass may
Inablation.
you can
Exoplatic.
do it with the you can do NSS, you can perform that. There's a something, one thing is called atypical angiomyolipoma, which shows some contrast enhancement during the CT scan. But only the biopsy can prove them it is a angiomyolipoma, not the. So they were atypical angiomyolipomas, but they are contrast enhancing, but they are benign. Okay.
So, Aditya, in this case, would you like to do a biopsy?
No,
Biopsy
sir.
would
No,
lead
sir.
to
No, sir.
increased risk of bleeding, sir.
Profuse
CNA.
hemorrhage may be
It is very vascular tumor, sir. Biopsy can lead to the hemorrhage. So it's better not to do renal biopsy in this case.
So classical angiomyolipoma is image findings. It doesn't need any biopsy, but
biopsy.
atypical, like equivocal tumor lesion, which is doubt of AML on the tumor, there you can do a biopsy. Okay.
Yes.
Yes, sir.
Yeah.
Swapnil, in this case, what is your diagnosis? Your diagnosis is angiomyolipoma, or you are still in doubt?
No, sir. In the sir, as a radiological feature suggestive of the angiomyolipoma, sir. So it's angiomyolipoma. So we can go ahead with the treatment, sir.
Okay.
And the
So
patient is
you
kidney,
want,
sir.
so what you will do now?
Most,
Let
Sir,
us ask Anand. Anand, what you want to do?
sir, the smaller angiomyolipoma in the upper bone, we can conserve it, and the lower one, which is more 5 centimeter, we can do NSS for that, sir.
Okay. And if because it is very near to the vessel, what you will do?
In this case, you would not like to do a scoring system, nephrometry score.
sir,
Nephrometry score was
nephrometry
given,
score
it was
is
10.
10.
Also, if there is a doubt,
Higher
if
complexity.
CT has raised a doubt that it is query angiomyolipoma, query RCC, can you do something else? Or you're convinced with the CT scan?
Sir, absence of calcification,
Sir,
more likely of angiomyolipoma.
The MRI
Suppose you have
report
a
also.
situation like
MRI.
this, suppose you have a situation like this where you are in doubt whether it's RCC or angiomyolipoma, can you do any other test?
Intraoperative, we can expose the sections.
Any other imaging?
MRI.
Yeah.
Very good.
So MRI is done. MRI is the one which was showing. Just tell them the report of the MRI, Vijay.
So there is a large partial exophatic focal well circumcised T2 signal intensity arterial phase enhancing fat containing lesion of renal nephromatous score 9P. Epicenter in the posterior labrum of the right kidney, straddling the upper pole line and involving both the upper and interpolar cortices, measuring approximately 3.4 by 3.9, 4.3 by 3.9 into 3.0 centimeter in size. Lesion bulges enteromedially into the renal sinus and distorts the upper polar infundibulocalyx and renal pelvis, resulting in moderate upper polar hydrocalcosis. Medially, the exophatic component bulges into the perinephric space and abuts the lateral surface of the right psoas muscle, but is contained within the perinephric space. Lesion is supplied by hypertrophied posterior lateral branch of the right renal artery and displaces the right renal vein, but in a non-angioinvasive way. And there is also a partially exophatic circumcised T2 intensity fat enhancing lesion of 1.2 cross 1 cross 1 from the posterior labrum upper pole of the kidney.
Okay, so what is
So
the
there are two,
conclusion?
yeah. So the two focal well circumcised exophatic fat containing solid lesions in the right kidney as described, and presence of bulky fat and absence of calcification in both the lesions are in favor of angiomyolipoma rather than fat containing RCCs.
Sir, in this case, I will plan this patient for partial nephrectomy, but depending on the complexity of the tumor, I will extend the patient if she may need radical nephrectomy, total nephrectomy, because the tumor is involved in the hilum. The chances of preservation of the renal parenchyma means there may be chances that total nephrectomy, radical nephrectomy can be needed.
Why don't you,
So all
would you not like to
all this-
observe the patient?
Sir, we can
Yes, sir,
observe the
then-
patient, but patient is symptomatic at present. It is likely to having more episodes of pain due to the size of the. So it's a progressive condition. So we can go for the surgical management at present.
So can we here say that if the patient is not planning any pregnancy in the near future, there is no active bleeding which
Sir,
could be seen on the CT or the
we can
MRI?
observe, sir, but we need
can
active
observe.
follow-up.
So other than pregnancy, the size of tumor and the accessibility toward the tertiary care center or other things also an important factor. So you
Yes.
should consider all factors while doing the management. Okay, you cannot focus on only one factor and ignore rest of the three. Okay.
So you call
Yes.
this as a progressive tumor. How did you conclude progressive?
Answer.
Because multiple episode of pain.
Pain and sir, maybe sir, size is more than 4 centimeters.
No, that is not an indication for progressive. To call it progressive, you should have serial radiological images which show increase in the size of the tumor or the AML.
Yes.
Okay. What are the other non-surgical options available for AML?
Angioembolization is one option, so selective angioembolization that can be done. That helps us to reduce the size.
Then, sir, cryo, thermal ablation.
Very good. Any drugs described for AML?
Yes, sir.
Sir, tyrosine kinase inhibitors.
Yes,
or
mTOR inhibitors.
mTOR inhibitors.
Everolimus
we can
can
give.
So if the tumor is at a size where say, surgery is going to be difficult, or if there are multiple tumors you could put the patient on mTOR inhibitors to slow down the progression, or you could consider angioembolization, though surgery remains the single curative treatment in a way.
Okay.
Fine. Anything else you want to add into this, Pankaj bhai?
No, sir. I agree with what Mahendra said, that just because it is more than 4 centimeters, we should not be pushing the patient for surgery. Yes, symptoms is one criteria, and you need to take everything else into consideration.
Because one more thing is that it is very near to the hilum and vessels. So if it progresses, there are chances that catastrophic, bleeding can also take place. So we must explain this to the patient.
True, sir.
Yeah. Okay. So I think that is one case. Now we are going to the last case. Brijesh.
So this happens, the patient came with PET CT scan, but outside it was not clinically relevant in this case.
So just tell us the conclusion. PET scan.
So PET scan had multiple lesions, multifocal pathology seen involving upper and mid poles of the right kidney, macroscopic fat within arterial enhancing and normal uptake. There are many pictures highly suggest angiomyolipoma.
Fine. So every investigation is now, except the CT, it was suggestive of angiomyolipoma. So we consider this as an angiomyolipoma and we can decide the line of treatment. Okay, case 3. Go ahead.
So this is a bit atypical case. A 27-year male presented with a complaint of urinary retention and hematuria since 12 hours.
Okay. So just show them the sonography report. Yeah, give. Tell them the history. Just tell them the full history.
So we did a urine routine examination, and albumin positive, acetone positive, blood was positive, innumerable red blood cells, and 10 to 12 pus cells, RIPA. He also sent, because he had a young age and hematuria, he also sent for culture and sensitivity, and also sent for gene export for TB. That came out to be negative. So this was the blood reports. His hemoglobin was 10.8, serum create was 0.9. Electrolytes and everything was within normal range. So we did a sonography.
Okay, Aditya, quickly tell us what are the findings.
So in the previous slide, the bladder, there is maybe a space occupying lesion, or say a hyperechoic lesion in the urinary bladder. In the image on the right side, the bladder appears normal capacity. The wall of the bladder looks normal.
So what is this probably?
Large bladder clot maybe, sir.
Yes. Okay. So it's a large bladder clot. And what do you see in the kidney?
In the kidney, sir, the left kidney appears to be in normal size and shape with normal corticometric differentiation. There is on the near the lower pole, there is a hyperechoic lesion, sir, which is a bit heterogeneous as well. Heterogeneous hyperechoic lesion.
What about the pelvis? There is a mild hydronephrosis.
Yes, sir.
Correct? And what
Yes,
do
sir,
you see in the
pelvis
pelvis?
Again, a clot can be maybe hyperechoic
Okay.
lesion, so maybe a clot can be seen in the pelvis.
Okay, fine. So patient has come in emergency with a clot retention, and you have decided to, because he is in severe pain, emergency, you have to take him. So what you will do now?
So primarily, a patient will be needing, after evaluation and all the blood investigation, patient will be needing a cystoscopy and clot evacuation. Prior to that, if possible, get an CT scan themselves just to confirm the source of bleeding. if you're able to find any source of bleeding, sir, contrast and CT scan would be preferred. Again,
Yeah, but
triple
this
chase.
yeah, I agree. But this patient came in the night at 2 o'clock with a severe pain. Okay.
Patient
We
has
can
come
place
with a 12-hour retention of urine.
a Foley's catheter primarily. We'll stabilize the patient, sir. Insert a Foley's catheter.
First is
Relieve
catheter.
his.
Yeah, but patient problem was that this clot was, obstructing, and it was basically a clot retention.
How much is the size of clot?
Roughly say 7-8 centimeter looking at the image.
So overall it is 24 cc. That's what they have written. And you are directly planning for cystoscopy. Twen 24 cc and cystoscopy.
वो पुराना वाला इमेज, इसके पहले वाला इमेज.
So it's just around 200 to 240 cc.
No. Show the report. Hematoma measuring approximately 4.5, 4.3, 2.3, 24 cc.
Yes, sir. So, three-way Foley's catheter, sir, primarily with the bladder wash and.
So giving a trial of three-way and bladder wash is not a bad idea.
Yes, sir.
Yes.
Sonographic.
Aditya, don't make the examiner ask multiple questions. Three-way, for next question, which size? Okay. Say everything in one breath what you want to say.
So a large bowl, so 22 French three-way Foley's catheter with bladder wash and slow irrigation. So we continue with them.
What is the protocol for bladder wash called?
Catch 22. Sir.
What does that mean?
So ideally we should use a 22 French Foley's catheter. With the catch is a mnemonic for CATC, so we should call for help. We should give antibiotics along with that. Then we should total irrigation should be given 1 liter once the urine becomes clear. Then C is for catheter again, and H is hydration.
Okay, chali. So you need a 22 French catheter, that is true. You need to cover the patient with antibiotic and analgesic. You need to give bladder wash till the return becomes clear and probably 1 liter beyond that. Okay. Because you need to be 100% sure that everything comes out. Okay. And if you are able to clear with a Foley catheter, very good. If not, then the next step would be to do a cystoscopy and clot evaluation.
Yeah. So in this, if you go to see, if you read properly, okay, the left kidney appears bulky and shows heterogeneous echo texture, right? And you can see that one hematoma, this thing is seen. 1 centimeter is noted in the renal pelvis. There is a thin rim of perinephric fluid is noted. And again, if you go to see, there is a minimal free fluid noted in the Morrison pouch. So these are some positive findings. And in spite of giving wash multiple times, it was getting clotted. Patient had severe pain in suprapubic region and bladder was full. So in emergency, we decided to do clot evacuation. Because many times we have seen that they say that it is 15 cc, 24 cc. But in fact, when you go inside, there's a large clotting. Okay, just show them how much we removed, amount of clot, and what was the finding.
Yes, sir. We approximately have around 240, 250 cc of the clot, and we did cystoscopy with lateralization of the source of bleeding. So I have the video in top. I will share that. So we did the clot evacuation and we could lateralize from left VUJ. There was reddish urine passing. So we tried to do a
No, एक
UR.
minute, one minute. So Aditya,
Yes.
now what we will do? Once you are saying that the bleeding is coming from the left side.
So then a flexible scope is something we would want to do and see the exact, if you're able to localize the source of bleeding, sir.
Okay, Anand, what you will like to do?
Yes, sir. I will see the upper tract at least active bleeding. As he's saying that active bleeding is coming from left bleeding.
So you will like to do any ureteroendoscopy or flexible, or you want to do RGP, or you don't want to do anything?
So first I would do RGP and then I would plan from then flexible.
Swapnil, what you want to do?
Sir, same. I would like to go for first RGP, and after that, I would like to go with flexible.
So
To
you first don't want
Yes, at this
just
time, or you
efflux.
want to wait and evaluate?
Active bleeding.
You just want to see a efflux or don't want to see efflux.
Sir, I would like to see for efflux first.
So
If
persistent hematuria
Sir,
and active hematuria, then you have to go in and see somewhere else where is from hematuria if it is possible. If it is not, there is no hematuria, then why want to go for RGP for that clot?
See, in presence of clot and
there was a bleeding.
even RGP will not
Yes,
help
sir.
you.
Sir, yeah, exactly. So if there is a persistent bleeding, what you will see by doing a scopy and RGP?
Even RIRS will not be a good option. It's bleeding actively.
Exactly. So your aim is to stop the bleeding. So by doing RGP, how will you stop the bleeding if it is active?
So Aditya, again, second time, what you will like to do? You don't want to do anything. You want to do DJ stenting. You want to do RGP. You want to do ureteroendoscopy, and you want to do flexible ureteroscopy. Come on, select. Don't worry, select. Even we have done things which may not be right or wrong. We don't. We will tell you what we have done.
All of you select one answer.
तुमको जो ठीक लगता हो बोल दो.
In emergency, we will do something.
DJ stenting will be most.
Okay, very good.
Okay.
So Swapnil will do DJ stenting. Aditya, what you will do?
Place a ureteric catheter. See the return from ureteric again.
You are inside the system. You are inside the bladder. Why you want to place the ureteric catheter and see the efflux outside?
अभी बोला ना कि RGP has got no role. Then also you are saying ureteric catheter.
You are in front of both the ureteric opening. You have to see the efflux.
Blood is coming, no, from ureter. It is seen. Blood is seen coming.
Persistent active bleeding, yes or no? If no, then you don't have to worry. You have to search for the cause by doing RGP, whatever you want to do, flexible ureteroscopy or jo bhi karna. If yes, then how you want to prevent that bleeding which is actively coming from above by doing RGP and flexible?
Brother, you see,
and how digestant will help in stopping the bleeding? Digestant will help in avoiding the clot colic. Agreed.
For bleeding, we just place a Foley's and get a to find the source of bleeding. Can we do a CT angiography?
Okay. So I will tell you that in emergency, I'm not, see, please understand, this is open for the discussion. This is what at 2 o'clock in the night, for example, when the patient comes and you may get tempted, and what you do, okay, this is what we have done. So we lateralized the bleeding. We saw that it is coming from the left side. So we thought that if something is there in the ureter or something, we will be able to identify and can decide the line of treatment. So attempted ureteroscopy, we went only up to the mid-ureter. We have not forced it. And we said, if it is not going, let us do the RGP. Okay. So now we did the RGP. Just show them the RGP.
Sir, exactly, sir. If RGP is suggesting a filling defect in the pelvis, it may be tumor, it may be tumor, it may be clot.
This is just open for the.
Agreed.
Again, I'm telling you, I'm not saying what is right and what is wrong. That is what we have already discussed. But in emergency, this is what was done. Just show.
RGP had this, sir, mild extravasation of the dye.
You don't have RGP film?
Yes, at present, sir, it's not available.
Okay. Anyway, so we have put that Foley's catheter. We have not done anything. And after that, we did the CT scan. Show the CT scan.
Yes, sir.
Okay, fine. Okay. So as you can see, there is some delay excretion from the upper fold, and there is extravasation, and there is a thin rim of collection all around the kidney. So Aditya, now this is the picture. Now what you want to do? Come on, fast.
So there is a filling defect also. There is a filling defect in the renal pelvic reflex system as well, sir.
Right.
Most likely could be clot, could be tumor, sir.
Okay. Fine. So what you will do? Just tell us.
Once the patient is, once you've stabilized the patient, sir, then we would plan for a flexible ureteroscopy. In the pelvis, we will want to see whether there is a clot or a tumor, sir. If tumor is there, we will take a biopsy for tissue diagnosis. If it's a...
Yeah. Okay, fine. So Anand, what you will like to do?
Yes, sir. I would like biopsy the tumor. Then, depending
Now,
on the findings,
you have, listen to me. You have put the Foley's catheter and you have done a CT scan. Now, how many days you want to wait? Cytology is negative. We have done it. I'll show you the report.
80%.
Just tell us what you like to do.
Sir, RGP chat box we have sent, sir.
Okay. So people can see it.
Sir, we can try with any injection like tranexamic acid and look for the if bleeding is stopping.
No. Now, I'll tell you what is happening. He is continuously getting clot, colic, and one thing. And second thing, in between he's getting obstruction because of the clot in the Foley's catheter. So we have to give him both. But there was no active bleeding. Okay, so Swapnik, how many days you will like to wait for going inside again?
Sir, at least 7 days I would wait to go inside. Sir.
Okay. So what we from did, where that 7 days figure come?
Sir,
so that settle the inflammation.
Sir, inflammation will settle in 3 to 4 days. So it is better to.
What do you want to do after 7?
Sir,
I did not understand.
Flexible scopy and look for the site exactly where from the bleeding or any lesion in the pelvis which is showing in the CT scan as a filling defect. I would like to
What
look
is
for
obstacle
that.
for doing the flexible ureteroscopy? Bleeding or inflammation?
Sir, bleeding.
Bleeding itself.
Bleeding, sir. We
So
will
you
not
should
able
wait
to
for
see.
clear up of the bleeding, or you should wait for inflammation. Why there is inflammation? So if
Bolo,
patient had a persistent clots in the system, lot of clots in the system and clot colic, then
Obstruction
here
locally
there,
usually.
here there is a definitely a role of this stent ureteric catheter, whatever you want to place for short time or long time, considering the amount of hematoma in the system. Sir told
Right.
that patient had a persistent clot colic. So for that clot colic, what you have done? Police catheter.
So you understood what sir is saying.
So,
I
so,
will tell you.
so when case is discussing, you keep watch on examiner, what he want to ask, what he is asking, where the viva he is going to take, and answer very clearly. Here, urology is like physics. Confusion को कोई scope नहीं है.
You see, let's revise few things here again. Now, if you look at this CT scan image, this filling defect, is it likely to be a tumor or a malignancy?
Or a clot. Could be a clot, sir. Clot.
Clot or tumor.
Sorry, a tumor or a clot. That is what I meant. Yeah.
More likely a clot, sir.
More like, why?
We can see the contrast all around the filling defect, sir.
All around
That
it.
is,
Okay.
there is something which is
If
floating
it's
in.
a tumor, more likely that it will be attached to a wall and contrast will not be seen all around it. And you could see some speckled area of calcification in a tumor. Okay.
Yes.
Now, the decision in this patient will be based on how this patient progresses over next 7 days. Obviously, if this patient is getting repeated clot colics, I will need to put a stent. If there are no clot colics and if the hematuria is not significant, then I would want to go slow. Let all the clots dissolve, let all the clots pass off. If you try to go in early, you will always find clots in the PCS and still you will not find anything. As far as possible, I would want to prevent upper tract instrumentation, because any instrumentation I do, whether I put a stent or a guide wire or a ureteroscope, I may be denuding or traumatizing the mucosa, which will make my identification of the lesions more difficult. Rather, this is a situation where you should try to do a wireless ureteroscopy. Even the guide wire you put can traumatize the mucosa, and you will not be able to find out whether this is a bleeding which has happened because of your wire or it is the lesion which is bleeding. So in active hematuria, there is no place for scopy. If active hematuria with repeated clot colic, stent, otherwise wait, hydrate the patient, bed rest, cover him well with antibiotics, see that he remains comfortable, see that urine remains clear, reassess CT scan once the urine is clear, after you have expected the clots to dissolve, and then take a decision. Don't be in a hurry to go up in the pelvic vessel system. Dr. Gite, you agree or you want to add anything?
Hey, Dr. Maheshwari.
I am totally agree.
I want to tell students, please, after this class, again listen to Dr. Maheshwari and write down in your book exactly all the steps what he has told you. Okay? I will tell you what we have done, but exactly what Dr. Maheshwari is telling you, that is the way you are going to follow. So well, this patient, because he used to have repeated obstruction because of clot, and he had no bleeding thereafter, but there were old clots which were coming down continuously. We waited for 7 days, repeated sonography, it didn't show any deterioration in leakage or perinephric fluid collection. Okay, we decided to do digest because he was getting. Again, we got little tempted, and because we have got that, suction
sheet available. We went inside, there was a clot in the ureter. We removed that clot, we went inside the kidney, and gently we tried to remove all the clot. In most of the clots we have been able to remove. We saw inside actually, there was no growth available. So we have put a device, but ideally, whatever Dr. Maheshwari has said, that is the right thing. Now, we have become little wiser. We are going to wait. Again, when the patient will come, we'll detect CT scan, we'll see there are no clots. And then only then we will again remove the digestion and with a clear, no hematuria, no clot inside, we do the RTR. So please follow all the steps what Dr. Maheshwari has told you. Yes.
In the US, sir, most of the centers, they are doing this, like Dr. Maheshwari said, no wire, no ureteroscopy, direct RIRS. That's how, sir, they are also doing sheathless RIRS. Therefore, they don't use access sheath also. And I think most of the series of Grasso, they're doing that only. So directly they put the RIRS, have a look so that you're doing a atraumatic scopy and you get to know, delineate the lesions very well. And in some cases where there is doubt, even NBI can be used, narrowband imaging, to find out the suspicious areas to take biopsy or something.
So the idea of putting this case is, you don't come across such cases, even when you start your practice. Hardly once or this is a second time which I have come across. Before that, sorry, third time. Before that, both the cases had a CT, I'm just saying, renal or urogenital amyloid. And that was we could take the biopsy and prove it. So in emergency, when you come across, maybe after 10 years, 15 years, when you practice, suddenly something like this will happen. Do very systematic. Okay?
Yes, sir.
Fine. So, Gite sir, you want to add anything? Dr. Hudedar is there. Dr. Hudedar, you want to share your experience or something?
No, sir.
Okay. I think we conclude here. Okay. Thank you. Good night to everybody.
Thank you, sir.
Thank you, sir.
Good night, sir. Thank you,
Good
sir.
night.
Good night, sir.
Good night, sir. Good night.
Good night.